So congenital heart disease is obviously my favorite subject. So at the end of the presentation, the hope would be that people understand the basic anatomy and pathophysiology of both acyanotic and cyanotic heart diseases, know the important components of diagnosing by history and exam, not to miss clues to diagnosis, basic management plan, how to evaluate a cyanotic newborn, and recognize and treat hypercyanotic spells. Does this sound like a good plan? I think it does. All right. So starting with acyanotic congenital heart disease. So pop question, which of the following acyanotic lesions should cause or would cause bounding pulses throughout the entire body? Large VSD, small PDA, severe aortic regurgitation, aortic coarctation, and severe pulmonary stenosis. All right, and the answer is, all right. So the answer is severe aortic regurgitation. So a large VSD shouldn't really interfere with what's happening in with the pulses. A large PDA can cause bounding pulses, but a small PDA should not. Severe aortic regurgitation, I'll show you why. Aortic coarctation can cause bounding pulses in the upper body, but not in the lower body. And severe pulmonary stenosis really should not have impact on your pulses. So if you have severe aortic regurgitation, all that blood in diastole is going back to the left ventricle. So this will steal blood away from your head and neck and leg vessels in diastole. This will cause low diastolic blood pressure, high pulse pressure, and bounding pulses. All right? So remember that. Again, a large PDA would give you the same. So acyanotic, starting with shunt lesions. So atrial septal defect is pretty common. It can happen in isolation or in association with other congenital heart diseases. There are multiple anatomic types of ASD, which I'll show you in a diagram. So the secundum ASD is in the center of the atrial septum. This is the most common, about 70% of all atrial septal defects. Primum ASD, it's part of the endocardial cushion spectrum or AV canal spectrum. So AV canal or endocardial cushion is generally, it's like a lesion of the center of the heart. And as part of that, you can have a primum ASD, abnormalities of the tricuspid and mitral valves, plus minus an inlet VSD. So it's part of a package and almost always requires repair. Primum ASD. On the other hand, sinus venosus ASD is less common. It occurs in the top part, superior part of the atrial septum, and since this is pretty close to the pulmonary veins that come to the left atrium, it is typically associated with partial anomalous pulmonary venous return. All right. Occasionally, ASDs are part of a genetic syndrome, such as the one we mentioned, Holt-Oram or Hart-Hand syndrome, but also could be part of other genetic syndromes like Noonan's. So what is the pathophysiology? So left atrial pressure is generally higher than right atrial pressure. So this favors a shunt from this direction in that direction. So left atrial to right atrial shunting. Although transiently people could have elevations in their right atrial pressure, which can force right to left shunting very transiently through the atrial septum. But this is what is the prerequisite for these paradoxical emboli that can cause strokes. But generally, it's a problem in left to right shunting. Oxygenated, so the problem is all this oxygenated blood, which is going to the pulmonary arteries, comes back pulmonary veins, and then a portion of that oxygenated blood will go back through the ASD, right atrium, right ventricle, pulmonary arteries, pulmonary veins, left atrium, right ventricle, pulmonary arteries, pulmonary veins, left atrium. So all this portion of the blood that's just recirculating over and over and over and going back to the lung, when it's already gone to the lungs and got oxygenated, it sort of recirculates ineffectively. And that's what causes what? Which side of the heart gets big? The right side of the heart gets big because it's mostly the one involved in that vicious cycle. So you have progressive right-sided enlargement, which can stretch your tricuspid valve, causing significant tricuspid regurgitation. Over time, this can cause significant atrial arrhythmias due to right atrial enlargement, and ultimately symptoms of congestive heart failure. But this typically does not happen in the youngsters. It takes long years and decades for symptoms of congestive heart failure. And if it goes uncorrected, all this excessive pulmonary blood flow will cause pulmonary vascular disease, and Eisenmenger with right to left shunting. Now my timer here says 25 minutes for some reason. I don't think I've been talking for 20 minutes. So symptoms of congestive heart failure can happen, and ultimately, if uncorrected, you'll have irreversible pulmonary vascular disease, which ultimately will reverse the shunt to be right to left and cause cyanosis. And by that time, they would be irreparable. So the clinical findings, again, have to do with right ventricular dilatation, therefore increased palpable right ventricular impulse, increase in the pulmonary blood flow, which causes a systolic ejection murmur at the left upper sternal border. Again, it's not that the pulmonary valve is stenotic, it's that it's relatively stenotic to the amount of blood that it's being asked to handle. And that's what produces a pulmonary flow murmur in these cases. In addition to that, for the same reason, there's too much flow going through the pulmonary valve, so there's delayed closure of the pulmonary valve, so there's a fixed split S2. Also, if you have massive shunt of more than 2 to 1, so pulmonary flow more than systemic flow of 2 to 1, so if there is more than 2 to 1 flow going through the tricuspid valve, for a similar reason, you will have a relative tricuspid stenosis, and that's what causes a diastolic flow rumble. So most patients with a small defect, no symptoms, and no or minimal volume overload can just be managed expectantly. All right? Many defects do close spontaneously. Those who do close spontaneously, this will happen over the first 2 years of life. And obviously, the smaller the defect, the higher the probability that that spontaneous closure would happen. And that's why you just sit on them, because again, most of them do not cause congestive heart failure early on, so you can sit on them and allow them to close spontaneously. Nowadays, when we do want to close them, we can do that in the cath lab using devices. There's like a gazillion devices nowadays. Most cases of secundum ASD can be closed with a device, starting these days in infancy, but we like to wait longer. Otherwise, if the defect is too big to be closed by a device, we still do open heart surgery. These are typically done electively by age 4 to 5 for shunts that are generally more than 1.5 to 2. Earlier repair if they have symptoms or they have significant volume overload, i.e. right ventricular enlargement. Medical therapy for congestive heart failure is rarely necessary for atrial septal defects. Next in line is ventricular septal defects, so holes in the ventricular septum. It is the most common congenital heart disease, 20%, can be either isolated or part of a more complex congenital heart disease like tetralogy, transposition with a VSD. There are obviously different types based on the location. The outlet VSD, we also call it subarterial, is sitting between the pulmonary valve on one end, so it's right underneath the pulmonary valve on one side and right underneath the aortic valve on one side. The reason we mention that is the aortic valve can actually get sucked into that defect, and this will cause aortic valve prolapse and regurgitation, which, when they do have that, we will recommend surgical repair. So moving on from outlet VSD, which is underneath the semilunar valves, we move now to the perimembranous VSD, which is the most common defect. These also can have the ability to regress or close spontaneously. How do they do that? Because they're close to the tricuspid valve. So a perimembranous VSD can close due to tricuspid valve tissue, sealing the defect over time. And inlet VSD, as I already alluded to, is part of the endocardial cushion defect, okay? So it's endocardial cushion or AV canal defects are lesions in the center of the heart that cause a primum ASD, abnormalities of the tricuspid and mitral valves, plus minus an inlet VSD. If they have an inlet VSD, we call them complete endocardial cushion defect. And those will most certainly require surgery. Muscular defects are pretty common, particularly in the newborns. They're usually small, and they usually regress spontaneously because they are surrounded by muscle. So the muscle can grow around them and seal them shut. But they can be challenging if we have multiple significant defects. We call this a Swiss cheese ventricular septum. So the pathophysiology has to do with the fact that LV pressure is greater than RV pressure, so you have a left to right shunt. But this doesn't happen right away after birth because, as you know, pulmonary artery pressure and pulmonary vascular resistance, they're high right after birth and they start dropping typically over 3 to 6 weeks. So the determinant of the degree of the shunt is obviously the size of the defect. The bigger the defect, the more the shunting. But it also has to do with the balance of the systemic, this is a typo, systemic vascular resistance to pulmonary vascular resistance. This is a major determinant in big defects. So the lower the pulmonary vascular resistance, the more this will invite shunting across a VSD. And as shunt increases, you start to have all the symptoms of congestive heart failure: tachypnea, diaphoresis, poor feeding, and failure to thrive. And this can start as early as 2 to 3 weeks if the pulmonary vascular resistance drops precipitously. On physical exam, think of the VSD just like we did for ASD. So if this is a VSD, so the blood will go from LV to RV, pulmonary valve, pulmonary artery, pulmonary veins, left atrium, left ventricle, right ventricle, pulmonary artery, pulmonary veins, left atrium, left ventricle. So the main chambers that are actually involved in overcirculation are actually the left atrium and the left ventricle, believe it or not. So, but murmur may be absent at birth if the pulmonary vascular resistance is high and there is minimal flow going through the VSD. So you may not hear a murmur right after birth. Or on the other end of the spectrum, if you have unrepaired patient who develop pulmonary vascular disease and Eisenmenger, you will also have, you won't be able to hear the VSD murmur because there's, very little flow going through the VSD. Since, again, the murmur happens immediately after ventricular contraction, we call it a holosystolic murmur or S1 coincident murmur. It is best heard at the left lower sternal border, and then the pitch of that murmur will depend on the pressure difference between the left ventricle and the right ventricle. So if you have a small deep VSD, it will cause a high-pitched murmur, versus the harsh, higher frequency murmurs with larger defects. In addition to the holosystolic murmur, because there's increased flow across the pulmonary valve, you will also hear a systolic ejection murmur at the left upper sternal border with moderate to large VSDs. And also because the overcirculation circuit involves, the mitral valve, if there is a QPQS of more than 2 to 1, you will also start hearing a mitral inflow rumble. So for ASD, we heard a tricuspid inflow rumble. For VSD, on the other hand, we hear a mitral inflow rumble. So S2 is typically normal with smaller defects, but then becomes loud and single in large VSDs with associated pulmonary hypertension. If you have a moderate to large VSD, you have a palpable thrill and increased precordial activity. Look for possible complications of a VSD. We already mentioned one of them, which is if the aortic valve prolapses through the VSD, you can hear the pathologic murmur, decrescendo diastolic murmur of aortic regurgitation, which is most commonly seen in outlet VSDs. Or if you see the patient has cyanosis and clubbed, like let's say you see a 30-year-old with a history of a VSD, and now they're cyanosed and clubbed and have a loud single S2 and the murmur of pulmonary regurgitation, then think that they should have been repaired a long time ago and now they have Eisenmenger. Natural history is that small defects are restrictive. They lead to a small shunt. They typically have normal PA pressure, minimal increased workload on the left ventricle, and 75% of those will close spontaneously in the first 2 years. But even if they do not, persistence into adulthood is generally a benign thing and no intervention is necessary. You just follow them and monitor for any complications. For moderate VSD, those moderate VSD, they can go both ways. They may be restrictive to pressure, but they can allow large shunting if the pulmonary vascular resistance is low enough. RV pressure is generally less than moderately elevated, but you do have increased workload on the left ventricle. So these are sort of in between small and large. Some of them need to be repaired. Some of them may not need to be repaired. Some moderate VSDs may regress or close spontaneously, which is less common than in small VSD. And surgery is indicated if we have significant shunting, volume overloading, or moderate pulmonary hypertension. And finally, a large VSD, which to us is defined as a VSD size that is comparable to aortic valve size. Why is that? Because if your blood sitting in the left ventricle, then if the VSD is equal in size to the aortic valve, and you sort of have equal choices of going this way or going this way. So that's the definition of a large defect. It also will equalize pressure between the left and the right ventricle, so it is unrestrictive to pressure. Symptoms will typically happen pretty quickly as soon as you have a drop in pulmonary vascular resistance. So around 3 to 6 weeks of age. They do require generally anticongestive therapy. They rarely close spontaneously, although can happen with muscular VSDs. And generally we have to repair large VSDs in the first 2 years of life. We do it earlier for very large defects, or if they have refractory symptoms, or if they have Down syndrome because they are at higher risk of developing irreversible pulmonary vascular disease. Surgery can be possible if they present late in the game, like at 10 years of age, if we document that their pulmonary vascular resistance is okay and they did not develop Eisenmenger. We can only do, so all of them will require surgery, not device closure, but a few of them can be closed by a device in muscular VSDs, not in perimembranous. In muscular VSDs, because you could put a device inside the muscle and not worry about heart block. But a perimembranous VSD has to be done surgically. PDA, or patent ductus arteriosus, we like 3-letter words in cardiology. So the next 3-letter words is PDA. Risk factors are prematurity and maternal rubella for the board's exam. Normal PDA closure happens as the oxygen tension increases and prostaglandin drop after birth. You initially have a functional closure, and then it really seals shut with fibrosis. So functional closure is the first couple of days of life. It's still prostaglandin sensitive at that point if you use PGE. But 2 or 3 weeks later, you will have anatomic closure, and you would not be able to open it back up with prostaglandins. So as the pulmonary vascular resistance decreases, you will have continuous left to right shunting across the PDA. So what will that cause? You will have increased pulmonary vascular markings on X-ray. We will have a continuous machinery murmur, which is typically in the left infraclavicular area. Because the overcirculation also involves pulmonary veins, left atrium, left ventricle, aorta, pulmonary arteries, left atrium, left ventricle. The left atrium and the left ventricle will become part of that overcirculation circuit, and they will become enlarged. Typically, it can cause congestive heart failure, particularly in preterm infants or if you have a very large PDA. And a large PDA will cause a wide pulse pressure because it's stealing blood away from the aorta during diastole, systole and diastole. But the diastolic runoff will cause diastolic lower blood pressures. So bounding pulses or wide pulse pressure, think aortic regurgitation or large patent ductus arteriosus. So PDA in premature babies, we generally use endomethacin, less than 10 days of age. Obviously, other things have been used. Fluid restriction, monitoring the renal function. Diuretics may be needed. They usually need more nutrition. And finally, that you can do surgical ligation if medical management fails. And many of us these days, like here at the Cleveland Clinic, we also use device closure. If you get a 3-year-old child with that silent PDA where you don't really hear it, but somehow you found it on an echocardiogram, most people would say no treatment is needed. On the other hand, most people would agree that if you have an audible PDA in an older child, you generally close them. Percutaneous closure with a device is feasible as little as 3 kilograms, or surgical ligation in some centers. If unrepaired, there is risk of infection, endocarditis or endarteritis, and finally Eisenmenger syndrome. All right, so I want to mention a few things about pre- and post-ductal SATs because we talk about pre- and post-ductal SATs in the nursery all the time. So I like to mention that for you to have a pre- and post-ductal SAT difference, for them to be different, first of all, there has to be a ductus, so you can have a pre-post-ductal SAT difference if you don't have a ductus. And second of all, for them to be different, there has to be right to left shunting through the ductus, right? If it's all left to right shunting through the ductus, why would the SATs here be different than the SATs here? It's only if it's this lower descending aorta is being contaminated, so to speak, by right to left shunting, will you have a difference between the upper and lower SATs. So when do you have right to left shunting across the PDA? Well, 2 conditions mainly. If the PA pressure is too high or the descending aortic pressure is too low, right? That's what will give you right to left shunting across the PDA. So when is the PA pressure too high? Well, when you have pulmonary hypertension, right? So the buzzwords in a newborn baby are respiratory distress, loud S2, risk factors for PPHN like meconium aspiration. On the other hand, descending aortic pressure can be too low if you have coarctation of the aorta, right? And in these cases, the lower body perfusion will depend on your ductus arteriosus. So this will improve with prostaglandin administration. So the buzzwords is 2 to 3 week old acidosis and decreased lower body pulses with lower sats in the lower body than the upper body, think coarctation. And finally, in hypoplastic left heart syndrome and critical aortic stenosis, there is minimal flow or no flow going through the aortic valve. So the entire aorta is depending on the PDA for perfusion. In these cases, you would not see a pre-post ductal sat difference because the entire aorta is being perfused through the ductus with lower saturation blood. All right, which congenital heart disease produces higher post-ductal sats? We're not going to do a multiple question for that. I'll just tell you that it's transposition. So the only lesion which will give you higher sats in the legs than the arms is transposition. I'm going to say one more time. The only lesion will give you higher sats in the legs than the arms is transposition, which is sort of the opposite of normal. So to have the opposite of normal, something has to be transposed, right? So acyanotic congenital heart disease, now we're moving on, not to shunt lesions, but to obstructive lesions. So pulmonary valve stenosis, pretty common, more common in Noonan syndrome, which will give you dysplastic pulmonary valve. Mostly produces no symptoms, except if you have very severe PS in older children, they can have fatigue. On the other hand, newborns with severe pulmonary stenosis will be symptomatic. They will typically have minimal flow through the pulmonary valve. They can have right to left shunting through the ASD because the blood cannot get out of the right heart, and they will therefore have cyanosis. In these cases, use prostaglandins. So pulmonary valve stenosis will produce a systolic ejection click at the left upper sternal border, varies with respiration, as opposed to what you'll see, aortic valve stenosis does not vary with respiration. So systolic click that varies with respiration. Again, S2 can be widely split as pulmonary stenosis becomes more severe. Why? Because the pulmonary valve is very thick and sluggish to move, so it will be sluggish to close, so we'll also have delayed closure of P2. Absent in most severe cases of pulmonary stenosis because you will not have an audible P2. Systolic ejection murmur at the left upper sternal border. Chest X-ray will typically be normal, except if you have post-stenotic dilatation of the main pulmonary artery, the MPA, the pulmonary artery silhouette, will be increased. Treatment for high pressure difference across the pulmonary valve is pulmonary valvotomy, which you can do in the cath lab or by surgery. Mild PS is usually not progressive. So if you find mild PS in a 6-month-old, chances are they're going to be mild pulmonary stenosis for the rest of their life. However, aortic valve stenosis is a little bit different story. Typically, it's due to a bicuspid aortic valve, which can cause both stenosis and or regurgitation. If you, again, a genetic syndrome that's linked to bicuspid aortic valve and coarctation, Turner syndrome. There are other forms of aortic stenosis not at the valve. They can either be above the valve, such as what you see with Williams syndrome, or below the valve, because either you have a membrane below the valve causing subvalvular stenosis, or such as what we see with hypertrophic obstructive cardiomyopathy. Newborns with critical AS, they will present with congestive heart failure and shock. They just cannot pump blood to the body, so use prostaglandins to support them. Older child usually does not have symptoms, except with severe aortic stenosis, they can have chest pain and exertional syncope. On exam, if severe AS, you can have a narrow pulse pressure, a systolic ejection click that does not vary with respiration, unlike the click of pulmonary valve stenosis. You typically have a right upper sternal border systolic ejection murmur that's harsh and radiates to the carotid and suprasternal notch. If you have subaortic stenosis, you will hear a left mid-sternal border murmur. If you have concomitant aortic regurgitation, such as with a bicuspid aortic valve, then in addition to the systolic ejection murmur, you hear a decrescendo diastolic murmur of aortic regurgitation. Aortic stenosis is usually progressive, unlike its pulmonary counterpart. Treatment is also balloon valvotomy, or if the valve is not repairable, you do replacement. All right? Coarctation of the aorta. So 5% of congenital heart disease, it is a ledge type of aortic obstruction. Usually, most of the time, it's opposite to the site of the patent ductus arteriosus insertion. You see it in Turner syndrome. Another syndrome that I did mention earlier is FACE. It's anomalies of the posterior fossa, facial hemangioma, arteries, cardiac, and eye abnormalities. Most of them are associated with the bicuspid aortic valve, so look for that click. If you have multiple obstructions on the left side, so coarctation, bicuspid aortic valve, mitral stenosis, etc., we call these Schoen's complex. And the clinical presentation would depend. They'll either present in the newborn period or they can present later on in life. If they present in the newborn, usually this is the critical coarctation. It happens typically at days to a couple weeks of life as the PDA closes. What will you have? You will see decreased lower body perfusion, which will manifest as either absent or very poor femoral pulses, right? Poor urine output because of decreased flow to the kidneys, acidosis, and shock. Now, if they completely fail because of coarctation and they go into shock, then all their pulses may be decreased. But if you catch them before that, then only the femoral pulses would be decreased and the upper pulses would be okay. And again, when you see that in a newborn, prostaglandins, because then you can help them perfuse their lower body through the PDA. This is it. So if you give them prostaglandins, you would be able to supply flow to the lower body in newborns. This is the typical site of aortic coarctation. What about if they escape detection in the newborn, they do okay, they present later on? How do they present? Well, that's why we do 4 extremity blood pressures. And in these cases, you'll find a hypertensive upper body, and it'll be much higher than the blood pressure in the lower body. Don't worry about these 2 statements. Decreased femoral pulses and brachiofemoral delay are the buzzwords. Absent femoral pulses in severe coarctation. You will also have a long systolic ejection murmur, which is typically heard in the left infraclavicular area, but importantly, because the aorta goes back like a candy cane, you will hear this murmur in the back. If long-standing coarctation, people will start developing these arterial collaterals, which are, I'll show you here. So arterial collaterals are blood vessels that develop from the upper body and somehow collateralize to the lower body to help increase flow to the lower body. And those are what cause continuous murmurs. And they will also, if you have prominent intercostal arteries as collaterals, this will produce the typical rib notching. Typically, this takes a few years for these collaterals to develop. All right, so we mentioned rib notching. Treatment. So when do you treat coarctation? Only the mildest case of coarctation, you don't treat them. But if they have hypertension or if they have upper to lower body blood pressure gradient or difference of more than 20, you generally do that. It can be done either surgically, where you resect the coarctation and do end-to-end anastomosis. The old-fashioned way, which is not very popular, is to use a left subclavian flap. And for older individuals, not for little babies, but for older individuals, we use percutaneous angioplasty and stent placement. All right, blue. Let's talk blue. So central cyanosis is blue color of the skin. So cyanosis is blue color of the skin, nail beds, and mucous membranes. Just know that you need at least 5 grams per deciliter of deoxygenated hemoglobin to actually see visible cyanosis. So in anemic patients, cyanosis may not be very evident because the total amount of deoxygenated hemoglobin may be less. On the other hand, if you have polycythemia, then you would be able to see visible cyanosis at milder degrees of hypoxemia. All right, peripheral cyanosis, we get a few consults a year of peripheral or acrocyanosis. It is benign, completely benign. They have normal SATs, but their distal arms and legs and around their lips, not inside their lips, but around their lips, they can look a little bit blue. It's due to increased oxygen extraction in the distal body and seen more with crying and cold exposure. It is completely benign. So first of all, if you see cyanosis, first of all, confirm it. Do they have low O2 stats or PaO2? And then once you confirm cyanosis, well, you say, where is it coming from? Is it coming from the lungs, the heart, or is it hematologic? So the major mechanisms of cardiac cyanosis, why do we have cardiac cyanosis? It's either because we have mixing of blood between the right and the left sides of the heart. We could also have decreased pulmonary blood flow due to critical obstruction to blood flow to the lungs. Or you could have abnormal connections where the blue blood is being streamlined towards the aorta, such as what you see with transposition. Or you could have multiple mechanisms in the same patient. What are some historical clues that would clue you in about the etiology of the cyanosis? In premature babies, they are more likely to have RDS as a cause of their desaturation. If you have meconium aspiration, this can cause pneumonia, pneumonitis, and pulmonary hypertension. If you have severe tachypnea and respiratory distress, it's generally a pulmonary origin. However, just know that if some cardiac lesions can produce respiratory distress, such as with left-sided obstruction, like hypoplastic left heart syndrome. Why? Because the blood cannot come out of the left of the left heart, so you'll have pulmonary venous congestion, which will cause respiratory distress. Also seen in total anomalous pulmonary venous return. But generally speaking, if they have respiratory distress, there's a pretty good chance they would have a pulmonary etiology. But on the other hand, if they're blue and they're sitting there and they don't care about it and they have normal work breathing or very comfortable tachypnea, then that is very suspicious for a cardiac etiology. So on the chest X-ray, you look for things like RDS, meconium, etc., that clue you into a pulmonary etiology. On the other hand, if you see cardiomegaly, that's a red flag for heart. Or if you see very decreased pulmonary vascularity, so you barely see pulmonary vascular markings, this suggests a cyanotic heart disease that is accompanied with decreased pulmonary blood flow. All right, so if echoes, or let's say you call the echocardiographer and you're waiting, what do you do in the meantime? Well, let's see if it's the heart or the lungs. So we do ABGs at rest, or on room air, and generally you will have a PaO2 of less than 100 in both. Where is that? So basically you'll have a PaO2 of less than 100 in both pulmonary and lung disease. And then you put them on 100% FiO2. If the PaO2 on 100% FiO2 is more than 150, they correct it with oxygen, so it's probably not the heart. On the other hand, if you put them on FiO2 of 100% and their PaO2 remains low, less than 100, then that confirms that there is cardiac mixing. Hematologic causes, mainly methemoglobinemia or polycythemia. Again, polycythemia, you will see cyanosis at at milder degrees of hypoxemia, or it can cause that ruddiness that looks like cyanosis. So always check a crit. So cardiac conditions that cause left to right shunting, such as ASD, VSD, PDA, will not cause cyanosis unless you leave them for 30 years and now they have Eisenmenger syndrome, right? But in a newborn, those should not cause cyanosis, generally speaking, by themselves. All right. Which of the following cyanotic heart diseases in a newborn can worsen with initiation of PGA? So you've seen me now say PGE, 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 because generally that's the right thing to do, except in one scenario where you could actually make them worse. So go ahead and read these and put your choice. And we can start the timer, please. All right. So the blue baby, that you may in fact make them worse with starting prostaglandin. Yes, so total anomalous pulmonary venous return can worsen with PGE. All the other ones should really get better with PGE. So you start PGE on a baby, on a cyanotic baby that you know from prenatal diagnosis that they have TGA. The baby continues to be very blue and acidotic. You call the pediatric cardiologist. What are they most likely to do in that scenario if they fail to become better with PGE in known transposition? What is their next course of action? So bicarb, you increase the dose of PGE, give them oxygen, you do a knee to chest position, or you do a septostomy. And the answer is yay. All right, so yes, this is what you do. None of these will really help. So complete transmission of the great arteries is the most common cyanotic heart disease in the newborn. Tetralogy is the most common cyanotic heart disease, but in a cyanotic newborn, because most tetralogies may not be blue at birth, think transposition. So it is more common in males, infants of diabetic moms. You have two parallel circulations. So as you'll see here, you have two parallel circulations. So this is transposition, and this is transposition with a ventricular septal defect. So blue blood is coming back from the body, then gets pumped back to the body, then comes back from the body, then gets pumped back to the body. On the other side of the heart, you have pink blood coming back from the lungs, gets pumped back to the lungs, comes back from the lungs, go back to the lungs. So these are parallel circulations, and the only way to survive is to create communications at either the atrial level or ventricular level or ductal level, all right? So the typical presentation is few hours of life, male, loud, single S2, usually absent murmur unless you have a coexistent VSD or pulmonary stenosis. They have cyanosis, initially comfortable tachypnea, but later on they could develop symptoms of CHF. You give them oxygen, they don't get better, think transposition. This is the only one that if they have a PDA, they could have differential cyanosis. So they have reverse differential cyanosis, so higher sats in the legs than the arms. As the PDA closes, now they develop profound degrees of cyanosis. The presentation could be more subtle in those that have a way of communication at either the ventricular level. So if they have a large VSD or a large ASD, they may not be as cyanotic. And finally, if they have, on top of that, they have pulmonary stenosis, you have decreased pulmonary blood flow, and they have the worst forms of cyanosis. Egg on a string appearance is generally due to the narrow mediastinum generated by transposition. How do you manage them? You have to improve the mixing between these two parallel circulations by either opening the ductus, and if that doesn't work to give you a better PaO2, then the cardiologist is going to do an atrial septostomy. All right? Now, how do you surgically repair them? There's a mistake at the great vessel level, so the ventricle is connected to the wrong artery. So how do you fix it? Well, you switch them and you make the ventricle connect to the correct artery, and you move the coronary arteries. This is the old-fashioned way of repair, where instead of fixing the mistake, they create another mistake by making the blue blood go to the left side of the heart. All right, so Tetralogy of Fallot is 10% of all congenital heart disease. Think also a percentage of them, a fair amount of them, will have the George. It's a combination of 4 findings. Again, they all have a VSD. This mouse is very sensitive. So a VSD, overriding aorta, pulmonary stenosis, and right ventricular hypertrophy. But they're all actually the result of the same thing. So this outlet septum, if you move it anteriorly, if you displace it anteriorly, this will lead to crowding of your pulmonary valve, so this will cause pulmonary stenosis. It will also open up a VSD. It will also drag the aortic valve with it and cause overriding of the aorta. And finally, because of the high pressures in the right ventricle, you will have right ventricular hypertrophy. There you go. We explained all 4 components with just one embryologic abnormality, which is anterior deviation of the outlet septum. So clinical features are primarily related to how much obstruction across the right ventricular outflow tract we have. And therefore, this will dictate the direction of flow of the ventricular septal defects. Typically, you have multi-level obstruction under the valve, at the pulmonary valve, above the pulmonary valve. If you have mild obstruction, you'll generally have adequate amount of pulmonary blood flow, and you will primarily have left to right shunting across the VSD. These are, we call them the pink TETs. On the other hand, if you have severe obstruction, you will have severely decreased pulmonary blood flow, and if blood cannot get out of the right ventricle, it will go right to left across the VSD, and this will cause cyanosis. This can be present right after birth in severe TETs, or it could develop worsening of the obstruction over months to years. You generally have a loud systolic ejection murmur from the pulmonary stenosis. You have a palpable thrill. You have a single S2, because the pulmonary valve usually is bad enough that it doesn't produce a sound. Variable cyanosis and clubbing if you leave it unrepaired. Chest X-ray is typically described as a boot-shaped heart because of the decreased shadow of the pulmonary artery and the upturned apex caused by right ventricular enlargement. So TET spells, they typically happen at a peak incidence of 2 to 4 months of age, rare before 2 months. They are usually happens as paroxysms of decrease in pulmonary blood flow and therefore increase in right to left shunting across the VSD. We speculate that it's due to spasm of the right ventricular outflow tract muscle or increased pulmonary vascular resistance, and it can be triggered by things like agitation and dehydration. The end result is always the same, that you have sudden onset of worsening of the right to left shunt, decreased PO2 and increased PCO2, which triggers the respiratory center drive to cause hyperpnea. So they're usually hyperpneic, they're agitated, they can have seizures, and in worst cases, they can actually have death from a TET spell. So how do you comfort them? And typically during a TET spell, you do not hear the murmur of pulmonary stenosis because usually the pulmonary outflow tract is completely closed, everything's going right to left, so the murmur will suddenly decrease. So how do you treat a TET spell? You try to make them comfortable. You do a knee to chest position, which is the equivalent of squatting in older children, and you force back more blood to the right ventricle to open up that outflow tract. You give them morphine if you're in the hospital, which suppresses inotropy and gives them anxiolysis. You give them oxygen to reduce pulmonary vascular resistance. And then if things are not improving, you do more aggressive interventions. You give them IV fluid boluses to increase the to increase the preload of the right ventricle. You treat the acidosis with bicarbonate. Vasoconstrictors, which will elevate pulmonary systemic vascular resistance and favor more left to right shunting. Or you could use IV beta blocker to slow the heart down and allow more right ventricular filling. Propranolol is more for long-term TET-spell prophylaxis. And finally, if all of these fail, then we put them under general anesthesia. Surgical treatment of Tetralogy of Fallot is basically you close the VST and you relieve the obstruction by resecting, all levels of obstruction, the muscle bundles, pulmonary valvotomy, etc. In some patients, the pulmonary valve may be too small that we have to do something called a transannular patch. We make an incision across the pulmonary annulus and we put a big old patch across it. Rarely do we need BT shunts if they present with cyanosis right after birth. So Epstein's anomaly, I don't want you to get confused because Epstein's anomaly many times can be acyanotic. In fact, most of them are acyanotic, but it can cause severe cyanosis in newborns. So I wanted to list it among the cyanotic heart diseases. It is an abnormality of the tricuspid valve where it fails to separate from the right ventricle. So you have the typical apical, so the tricuspid valve forms from the right ventricle, and if it fails to separate from the right ventricle, then it's stuck to it. So instead of having normal separation, which is a normal development, the tricuspid valve is stuck, and that's what causes Epstein's. It looks like this on echo, like this on pathologic specimen. There's a huge clinical spectrum. They can either present in utero with massive tricuspid regurgitation and high drops, or they can be completely asymptomatic as an adult. But just know that the newborn presentation, when they present as newborns, they have basically all their right ventricular output is going backward through the tricuspid valve. There is very little pulmonary blood flow. Because of their severe tricuspid regurgitation and right atrial enlargement, they can have right-left shunting across their PFO or ASD, so they can be profoundly blue. And Epstein's will produce some of the most massive degrees of cardiomegaly you see on the chest X-ray. So if you see a massively enlarged heart, particularly in a newborn, think Epstein's. Okay, that's a board review thing. All right, how do you support them? Inotropes to improve their cardiac output, PGE, again, in a cyanotic newborn, improve flow through the PDA, or nitric oxide to make it easier for the right ventricle to pump forward than backward. Later presentation, if they have not so much tricuspid regurgitation, they can present later with fatigue and exercise intolerance. They can have mild desaturation if they have some right-to-left shunting across the ASD. They have a hepatomegaly and a holosystolic murmur of tricuspid regurgitation. If you leave them unrepaired, they can have significant right atrial enlargement and right atrial arrhythmias. And as Pete will probably mention, 30% will have WPW, and therefore they can have SVT. How do you repair them? By repairing the tricuspid valve. Truncus arteriosus is failure of normal partitioning of the outflow tracts into the aorta and the pulmonary artery. So instead of having two outflow tracts, you basically have one common arterial trunk that gives rise to your aorta, to your pulmonary arteries, and to your coronary arteries. And the aortic valves and the pulmonary valves will morph into this truncal valve, which typically is abnormal. And basically you have a big VSD, and both the right ventricle and left ventricle will share that common arterial trunk through the VSD, so they both pump blood to the VSD. Some of it will go out the aorta, and a lot of it will go out to the pulmonary arteries. Because of that, they typically will have excessive pulmonary blood flow, and because of their excessive pulmonary blood flow, they may not have as much cyanosis as some other cyanotic heart defects, but they will typically have a lot of issues with heart failure. There's too much pulmonary blood flow, so they have hepatomegaly, jugular venous distension, tachypnea. Because of the continuous flow, you will typically have a continuous murmur and bounding pulses. So this is another one that produces bounding pulses. I'm going to skip through those. And if they have dysmorphic features with truncus, think the George. Again, this is an example of cyanotic heart disease that actually produces increased pulmonary vascular markings. So you actually have increased pulmonary blood flow. You rarely need PGE for truncus arteriosus. Do not give them oxygen because it will make their pulmonary overcirculation worse. And you generally don't leave them for long, so you do surgery at a few weeks of life. Total anomalous pulmonary venous return, we mentioned it several times. So basically, it's when all the veins that normally should come back to the left side of the heart come back somehow to the right side of the heart instead. And they do so by either connecting to the above the heart, so supracardiac, they come back to the SVC, back to the right atrium, or they connect directly to the right atrium, you call that cardiac, or all the pulmonary veins come back infracardiac, typically to the IVC ultimately, and back to the right heart. So or they can be mixed, some above the heart, some below the heart. Physiologically, we divide total anomalous pulmonary venous return in either those that have obstruction or no obstruction. And surgical repair is basically we have to plug the pulmonary veins back to where they're supposed to go, which is the left atrium. So since there is no pulmonary venous return to the left atrium, nothing whatsoever. So you are dependent on the existence of an atrial shunt, which allows some of that blood to go to the left atrium and perfuse your body. So you have an obligate right to left shunt through an ASD, and that's why you have cyanosis. Cyanosis is usually milder, but generally if you give them prostaglandins, you cause more pulmonary blood flow, and you can worsen the pulmonary venous congestion and cause more problems. So generally they have a hyperactive right ventricular impulse, they have increased pulmonary blood flow, and they can be very sick for two reasons. Either if they have pulmonary venous obstruction, so somehow along the way the pulmonary veins gets pinched and have obstructed pulmonary veins, those can be very sick. Or if you have a very small atrial communication, they will present with low cardiac output because they are not able to have enough blood flow through the left side of the heart. So if they have pulmonary venous obstruction, the classic chest x-ray is a snowman in a snowstorm. So the pulmonary veins are obstructed. So if you see an x-ray like this and think of total veins. If you think it's RDS and you treat them for RDS and they don't get better, think of total veins. All right? And if you use prostaglandins in somebody like this and that you make them worse, also think of total anomalous pulmonary venous return. I'm going to briefly mention one last entity before we close, which is hypoplastic left heart syndrome. It is the most common type of single ventricle. So it is a spectrum of cardiac abnormalities characterized by smallness of the left side, left ventricle, mitral valve, aorta, uniformly lethal if unpalliated. Natural history is that they appear well after birth with subtle cyanosis, but they quickly crash. So as soon as the ductus closes, they rapidly decompensate in the first few days of life. But nowadays, we can save them by doing Norwood or heart transplantation. They can have a spectrum from either mitral and aortic stenosis to mitral and aortic atresia. How do you manage them? Also with prostaglandins, because you want to supply blood flow to your body. And you have to, and from that ventricle, you can either go to the body or go to the lungs, and so you want to manage that QPQS by manipulating pulmonary vascular resistance and systemic vascular resistance to have nice balance to your aorta and your pulmonary arteries. And finally, you do the Norwood operation, which is a reconstruction of the aorta. So that we have three goals: to have unobstructed systemic outflow by arch reconstruction. You have to have unobstructed pulmonary venous return. All the pulmonary veins cannot go to the left heart, so you have to have a big old ASD. And finally, you have to give them adequate pulmonary blood flow through a BT shunt. So the second step after, I'm going to skip through those slices. I honestly put them more for completeness than I don't think they're necessary for the board. But just know that after you do a Norwood in a hypoplastic left heart syndrome, the next step would be something that's called a Glenn operation. So this is the Glenn operation. You say, I want all the blue blood coming back from my head to not come back to the heart. I want it to go and directly to the pulmonary arteries. So you do a Glenn operation, which is generally done at 6 months of age. And then ultimately, you do the Fontan operation, which is basically you bring all the IVC blue blood straight to the pulmonary arteries. So at the end of the Glenn and Fontan operation, all the blue blood will go directly to the pulmonary arteries, and that single ventricle will only be handling the pink blood coming back from the lungs and pumping it to the body. And finally, there's a slide about cyanotic congenital heart disease. What are the complications of unrepaired cyanotic heart disease? So you have erythrocytosis, which typically would produce symptoms at a hematocrit of more than 65. You can have relative anemia secondary, to iron deficiency, even though they have erythrocytosis, but you can kind of consume all your iron stores. They can have a stroke due to paradoxical embolisms, brain abscesses, bleeding disorders and thrombosis, hypercyanotic spells, and that's it, folks.